20 patients, do all the blood work, and then present all the patients in the NICU to the faculty. And at that point in time, it was very little in the way of echocardiography, and our ability to evaluate common neonatal problems really didn't, exist. And, kind of I got interested in that, and one of my seniors had some interest in it, and that really was the start of, exploratory evaluation of the cardiovascular system. And there wasn't a lot that we could do in 1995. You see the PDA screen, or what they call here is the 1995 sign. So much I said in 1995, the only way we could evaluate the ductus was look at a Doppler in the main pulmonary artery, and you would see a turbulent flow pattern like what you can see on the bottom, and that we would suspect that there may be a PDA. 1995, was a long time ago. If you look at the world changes. I just put these pictures together of what a computer looked like, what a phone looked like. Blockbuster, how you would go and watch movies. It doesn't exist anymore. Blackburn were the Premier League champions. They're now in the doldrums of the English division. And kind of Brazil were the World Cup champions, and Brazil soccer is not the same as it is today. So the world has changed a lot. However, one of our prevalent concerns at that point in time was, how do we evaluate and monitor the cardiovascular system? And in 1995, it was very much a blood pressure eccentric approach to cardiovascular care. And that was very much driven by this BPA report in 1992, which, and you can see on the left-hand side, concluded that we don't know what a normal blood pressure is for preterm infants, but it seems to approximate the gestational age. And that concept became a dogmatic standard that, sadly, although we're in the year 2024, is still the standard. So the world has changed in many respects, but in many NICUs, this still exists. And the lack of progress, is somewhat concerning. John Skinner, who was a New Zealand pediatric cardiologist, was actually one of the first individuals to, start promoting that, who are the best people to actually perform echocardiography in the NICU. And he recognized at the time that, the cardiologists were not that engaged in neonatal hemodynamic problems. Their primary focus was congenital heart disease. And he published a sentinel paper, Echo in the NICU, a job for the neonatologist and the cardiologist. And he went on with others to publish one of the first textbooks, which many of us had at the time, on echo for the neonatologist. The concept of imaging by the primary provider is not new. Okay, since the early 1970s, imaging has been part and parcel of the work of pediatric cardiologists. Echo used to be performed by radiologists until the late 1970s. And interestingly, the cardiologists at the time had a big battle with radiology to be able to do their own echocardiography. And the argument was, we're the ones looking after the patients longitudinally, very similar to the argument that was being presented by the neonatologists in the late 90s, early 2000s. Some of the initial data on kind of clinician-performed imaging really came from adults, and there were 2 or 3 kind of sentinel papers in the early 2000s, which really reported on enhanced diagnostic accuracy and sentinel changes in management that appeared to be associated with clinical improvement. On my journey, one of the there are sentinel things in one's life that really have a huge impact on you, and probably one of the most sentinel impacts was when I was a pediatric registrar, kind of in Basildon Hospital, which is a kind of a level 2+ NICU on the east end of London in Essex. And I had, again, not done a 1-year structured fellowship like what we do today, but had been learning with pediatric cardiologists initially in Ireland and then in London. But there was a baby in the NICU who was a 3-week-old infant, having frequent apneas, respiratory distress. The chest X-ray showed an enlarged heart. And having had the skill, my neonatologist said, "Hey, can you have a look at this baby's heart?" So this is not the exact image of what we saw. This is a representative image kind of from several years ago, and Amish knows this case well. But what I saw was something like this, a big black shadow around the heart, which was not contracting very, very well. So I reached out to Mike Rigby, who's a pediatric cardiologist in the Brompton Hospital in London, and told him the story. We didn't have iPhones. I couldn't send him the pictures. I couldn't send the echoes, but I described what I saw. And he said, sounds like you've got a pericardial effusion there. You should drain it. So kind of cavalier fellow went ahead, drained, and took 25 mils of TPN off this baby's heart. Now, why was this impactful? In the year 1997, the whole PICC line causing tamponade, causing unexpected death in the NICU, really had not hit the public press. It only was in 2003 when the British Pediatric Society kind of wrote a consensus document on the need for mandatory screening of these patients. So this was not on people's mind. And certainly this was a life saved. You know, the likelihood if this baby had arrested that somebody would think to put a needle in the heart was incredibly low. So from this day forward, this was something to me that was very, very important. And we as neonatologists needed to take responsibility for building the field that mattered to us, and so forth. The troubled 2000s, you know, Nick Evans published a paper in 2000 suggesting that, or reporting that 40% of NICUs in Australia were performing echocardiography. And that was followed by a series of kind of criticisms based on risk, liability, missing congenital heart disease, reporting, you know, kind of particularly in Australia, kind of in the neonatal period that the risk is high, and was very much targeted against the neonatologists, but without actually sharing that the errors that we're seeing were not errors by neonatologists, but were by kind of adult cardiologists. However, this is still important. The neonatologist is not immune, and anatomic evaluation is not what we are trained to do. So in 2001, I crossed the Atlantic and arrived at Sick Kids Hospital as part of a kind of a fellowship, which was a hybrid fellowship. And during the day, I worked with Jeff Smallhorn, who you can see on the picture on the bottom, who was an absolutely wonderful pediatric cardiologist. He was the head of the echo lab. And he had a very open-minded opinion, you know, to this. But my primary role at that point in time was to enhance my skills of imaging, learn how to do the comprehensive assessment, and to perform academic endeavors. And actually, one of the projects that we worked on at the time was 3D echo and the impact of the PDA on the left heart. And that's the machine that we had at the time, the Accuson. And you can see at the bottom, you know, that thing, this was the probe, which was kind of fixed to the chest. And, you know, it's kind of sad that we are now in the year 2024, we're 20 plus years on, and actually 3D echo really has not made much progress forward. And I think a lot of that relates to the fact that the emphasis of development from an imaging company's perspective is more directed towards adults and children with congenital heart disease, and less so to the population that we take care of and care about. The bigger issue at that point in time was, you know, concerned by myself and others that, you know, we have really made very little progress, whether it's hypotension, PDA, pulmonary hypertension. You know, clinical trials suggest that treating all of these things doesn't seem to change outcomes. The fundamental questions, however, that existed were, you know, how good are we at defining the disease populations, characterizing patients that actually might benefit from treatment? Are our therapies efficacious and universally efficacious? And are we actually choosing the right outcomes? You know, and are we actually simplifying down something that's incredibly complex? The problems that we ran into and the problems that were kind of, you know, widely kind of available across neonatology really fall into 3 to 4 categories. Number one, most care was very much driven by symptoms. And you can give therapies for symptoms, but the same symptom complex may be explained by different disease states, some of which may require different therapies, and some of which, if you choose the wrong therapy, you may actually cause harm. The second was siloed thinking. We had this habit of putting heart symptoms into one bucket, lung symptoms into another bucket. So in the NICU, when you have a blood gas and it shows respiratory acidosis, most neonatologists and most centers will go to the ventilator and they will increase something on the basis that perhaps the lung is not recruited, tidal volume is not adequate. but failing to recognize that if you don't have adequate pulmonary blood flow, you're not going to clear carbon dioxide. So things are much more complicated. Thirdly, the physiologic disconnect, and this still exists today and was the basis for a recent editorial. I put this up again to remind people, this is the holy grail of intensive care. And we need to be thinking about these concepts and integrating them into our care on a daily basis. And then finally, the model, and what I would call the anatomology model, was not really what the neonatologist needed. The neonatologist has a clinical question, a technician who knows nothing about the patient takes a series of images, and these are interpreted by a cardiologist who is looking at the pictures, knows nothing about the baby, knows nothing about the ventilation, the fluid balance, the drugs, the electrolytes, and so forth. So you have this real disconnect. And to add to it, the inability to actually perform longitudinal studies. So these were the challenges that we were faced. So how do we move beyond the status quo? Well, first recognizing that cardiovascular physiology is complex and dynamic, and second, that perhaps a lot of our treatment benefit relates to diagnostic, and therapeutic imprecision, and that's really kind of emphasized the most in clinical trials. And when I say to people, if you go to the family doctor and your blood sugar is elevated, and he then asks you, would you be happy to be randomized to insulin or placebo? We're studying if this decreases glucose. You would say, don't you need to confirm first that I have diabetes? Okay. Unfortunately, in neonatology, we have not spent the time emphasizing the purity of diagnosis. Things took a turn around 2004 when the Neonatal Hemodynamics Club was built, and this was the brainchild of Istvan Seri in the middle. And the first meeting, and of Michael Weinlein from Liverpool and Nick Evans from Australia, talked about moving beyond blood pressure and the importance of systemic blood flow. And recognizing that our goal, as I say, in fixing the human engine, is to optimize the balance between oxygen delivery and oxygen consumption. Recognizing that oxygen delivery is a function of hemoglobin, lung recruitment, and the adequacy of cardiac output, which is influenced by the loading conditions of the heart. Remembering that blood pressure is important, but it is not a disease. It is not the thing singularly at all costs does one primarily focus on, but it's a symptom that you integrate into the care of your patients. So we entered into this era between 2005 and 2011, but I would say the era of political turmoil. There was great interest by neonatologists in the field of hemodynamics. And of the ECHO lab director who had helped me start off left, and when I approached the ECHO lab lead at SickKids to build a collaborative program, there was a resistance to do that. Despite the fact that there was emerging data that actually this is helping patient care and so forward. So the early days of hemodynamics at SickKids, were not easy. Okay, you can see there's a picture of two echo machines. The one on the left that's all we had. We had the Sonosite, which was very good, but at least it got us, started off. Training looked nothing like it does today. And many great people have been trained in this model, but it was very much a kind of a hands-on supervised session for 12 weeks, ongoing scanning, people kept logbooks, et cetera, but, there really was not formal evaluation. This was not competency-based. There was no time in the ECHO lab. This was exclusively within the NICU, and that happened because of the lack of interest by pediatric cardiology to participate in it. And my division director at the time said, this needs to happen. I will back you up and I will support you to make it happen. So, then over the next number of years, more people started to be trained. In 2007, actually, was the first national debate on this topic. And my good friend Keith Barrington and I, debated to get an Irish person and an English person in the same room debating about a topic was super interesting and super exciting. And, the conclusion at the time, and this is the exact slide that I kind of ended up with, was that clinical assessment alone is too imprecise. It doesn't tell you what's wrong. And, we talked about functional echocardiography as a valuable and adjunctive tool that would be available for the neonatologists to enhance the care. So how did we reestablish a collaboration? And Andrew Eddington was the director of pediatric cardiology. Kind of at the time, he moved on to be the director at Cincinnati Children's. And he understood and recognized that this was important. He recognized that pediatric cardiology was not interested, not engaged in doing the research, in characterizing the patient population. And, he was responsible for the knight in shining armor, Luke Mertens, who came to SickKids, from Belgium. And, one of Luke's first goals was to reach out to me to say, hey, why are you guys in the NICU doing all this echocardiography unilaterally and not engaging with us, et cetera, et cetera. And I said to Luke, Luke, we've been asking for this for the last 6 years. We've just not had the partnership available to do that. So this led to ultimately the guidelines for targeted neonatal echo, which were published in 2011. And what they did was they provided the political endorsement nationally, internationally, that with the appropriate framework, with the appropriate collaboration, it is acceptable, appropriate for neonatologists to engage in echocardiography. And you can see that we had a writing group which had 10 people, of whom kind of only 3 of whom were neonatologists. But it was groundbreaking. It really led to the foundation of the initial and largest program at the time in the world, the Toronto Hemodynamics program, which was a tri-hospital collaboration. And some of the people that who are on this call today, some of whom are in heaven, were the pioneers in working with me to build a very strong, foundation, which had, many, many dimensions. Nobody can build this on their own. And each of these individuals, Reagan, Afif, Danny, Amish, and others, really helped reshape the field to what it is today. The first thing that happened was transitioning from a neonatologist doing an echo to actually, if we are to build the expert model, this needs to be a consultation model. The likelihood that every neonatologist that can perform echo within the NICU and maintain skills, maintain competency, build academia really is low. And within this led to the importance of physiology, the importance of pharmacology, and actually developing a very standardized and consistent kind of approach. And Audrey Baer's paper kind of really emphasized the importance of the consultation. The second was the establishment of the Hemodynamics Fellowship. And the images here are just from the fellowship that we have now here in Iowa. But, the year of training, which was predominantly focused on kind of neonates, kind of would really provide the magnitude of the learning needed by neonatologists to be able to acquire the skill to perform advanced echocardiography and integrate that information. There were other things that we embraced thanks to kind of Afif Al-Kafash, in the early 2012 was the launching of the Targeted Neonatal app as an adjunctive tool with the complementary website to be able to support learning, not just kind of in North America, but all across the world. And that app was updated in 2019. I think Reagan took the lead on that in version 2. Simulation came along. And one of the challenges that was faced in other parts of the world is they don't have echo labs. It's difficult to actually have the degree of training and exposure to congenital heart disease that is needed. And actually in 2016, we had the National T&E Simulation Day, in Toronto, really highlighting the importance of this as an adjunctive tool for learning. So over the next 10 years after the guideline, the field changed remarkably. Amish pointed out the establishment of the special interest group at the American Society of Echo, and that's something that ACE are incredibly proud of and really highlight the importance of this. But if you look at the graph on the right-hand side, you can look and see this explosion in academic productivity by neonatologists, and not just neonatologists, but also some pediatric cardiologists in topics related to the NICU. There was a growth in members of our specialty interest group, an increase in productivity from a peer-reviewed publications, and many neonatologists, and nobody better than Amish, engaging in actually proper funding of research to kind of further mature the field. Thanks to the brainchild of Amish Jain, we launched the Neonatal Hemodynamics Research Center, which really is a virtual academic interface in which neonatologists, not just from US and Canada, but all across the world, engage in educational activities, some research activities, and so forth. And that has grown and expanded significantly over the last 10 years, and something that we're very, very proud of. Probably one of the most exciting part really has been the advancements in science. And again, I'm not going to go into any details here, but they have transcended, 4 to 5 domains, which are equally important. And in establishing a new field, it is key, to engage in validating the imaging techniques, and kind of studies comparing echo to MRI, for example, normative data generation, and there's still work to be done there, particularly in the extremely preterm babies under 25 weeks gestational age. Most of the focus really has been on characterization of disease, pharmacological appraisal of therapies, and more recently, clinical trials, several of which are ongoing in Canada, and we're about to launch one here in the United States. So I want to take a pivot now to look at, okay, what have we learned in building the field? And some of my early work really focused on the PD ligation population, and how do we take a clinical problem and actually generate meaningful evidence that may kind of change practice. This actually started off as an administrative responsibility, and I was asked to solve a problem in Toronto whereby there were massive delays in babies getting in for PD ligation. And what that led to was, the development of a categorization system, for infants to make sure who comes first. It also led to more standardization of the evaluation of the ductus arteriosus. And you can see, actually, over time, the rate of PDS surgery actually decreased in Toronto. But the two big impacts of this were, the publication of kind of this paper in 2007, which really said that clinical trials should be less pragmatic and focused on more strict criteria for evaluation of the ductus arteriosus. And this concept of a multi-parametric assessment was born. But the second thing that came out of this was, when I started to get interested in this patient population, I started to notice that babies would go for PD ligation and would come back in the morning, like this case here, and the infant would be profoundly unwell with oxygenation failure on massive doses of vasopressors. And this sentinel case, the actual baby died from cardiorespiratory failure on day 2. What was this? Why did it happen? Could we have prevented it? So we started off with a retrospective evaluation of, what is this problem? And what we discovered was that this was a consistent problem that happened to some babies, and it was characterized by oxygenation and ventilation failure and the development of systolic hypotension requiring cardiovascular support. And you can see it says need for vasopressor. Vasopressor is not the right solution for systolic hypotension, but most people recognize this late, in which the blood pressure, the mean and the diastolic, then eventually failed. So babies would look like kind of this at 1 hour. Their lungs would look great after you close the ductus, and then by 12 hours later, they would look much, much worse. And as you can see from the probability graph on the left-hand side, this was inversely related to postnatal age, that the younger and smaller babies were the ones that were more likely to get sick. So our next step was to try to characterize the physiology, and not going into the details here, but a series of publications that many of you on this call were involved in here really highlighted that this was a cardiovascular event related to the change in afterload. As you can see on the right-hand side, the stress-velocity relationship at 8 hours was much steeper than the pre-intervention value, which highlighted that afterload was probably the predominant driver of the instability. And afterload, through its impact on systolic and diastolic function, provided a very biologically plausible argument for the hypotension and the pulmonary edema and respiratory deterioration. So what happened? On the two things happen after you close the ductus. One, preload drops, but it drops from high to normal. And if preload was the driver of this instability, you would have expected the babies to become sick immediately, as opposed to afterload, which increases and is sustained for a period of time. And as I tell people, you can't bench press all day long. The muscles will fatigue and so forth. What was particularly interesting was we actually had this window of opportunity before the baby's systolic and mean fell to try to make a difference. So can we intervene? And that was the third phase. Milrinone was a drug that biologically made a lot of sense through its predominant vasodilator effects, but also it works as an inotrope and an lusitrope. It's a drug that's been used with increasing frequency in the NICU. So it made sense. So we introduced this as a standard of care in the NICU in Toronto based on ECHO guidance. And this was Amish's JP's paper. Again, not big numbers, but certainly, very hypothesis generating that within a standardized approach with the targeted use of milrinone, that these babies, were less likely to become sick. And in the subsequent years, the incidence remained low. Obviously, one of the things that's important when you do research and you show one finding is to try to validate that. And kind of later a FEEF, performed this evaluation here using more advanced echocardiography measures and showed that those infants who had the lowest cardiac output at 1 hour, which had impaired LV strain, by 18 hours had recovered to an LV strain value that was comparable with the babies that didn't get sick. In the intervening years, other investigators have, highlighted that this is important, that infants who get sick after PDA closure are more likely to have more severe BPD, go home on oxygen, and also potentially to have a higher instance of abnormal neurodevelopmental outcome, kind of at 2 years of age. So this is an important problem. Things have changed, and we've moved from PDA surgery as the primary modality to transcatheter closure as the primary modality. So one of the next questions became, well, what happens to those babies? There's a lot of controversy over this, and there are many interventional cardiologists who will say that no, our babies don't get sick after PDA closure. This is a case of a baby here in Iowa. Actually, we use the same approach that we use in Toronto, using early echo, looking at the outputs and looking at LV strain to characterize the patients. And this infant kind of met the criteria for intervention, was started on milrinone, but by 12 hours was still sick, had significant oxygenation and ventilation failure. His blood pressures, however, were very high, and the astute clinician overnight decided to increase the milrinone from 0.25 to 0.5. And by the next morning, things had improved. The chest X-ray had improved and the FiO2 had come down. So, is this lung disease or is this heart disease? The siloed thinker will say this is a lung problem. Okay, but after PDA closure, you're going to have a reduction in preload to the left heart, but you've got a massive increase in left end systolic and end diastolic pressure due to the effects of increased SVR. And again, going back to the algorithm, it does seem to make sense that this same entity can exist after cath closure. Adrienne Bischoff, in one of her early studies, actually characterized that babies do indeed get sick, characterized by an increase in their FiO2 and respiratory severity score. But unlike the surgery population, this is not a hypotensive illness. This is an illness that's characterized by hypertension. And using these interesting HUTs, what Adrienne showed is that, yes, preload is reduced after the procedure, but arterial elastance and systolic elastance, which are measures of the impact of afterload on the heart, were significantly increased. And in a series of other studies, the infants who got sick had much, much higher values. So to take it to the next level, is this just a problem that happens in Iowa? Given the doubters that this occurs after PDA closure. So we published this very comprehensive evaluation, and when we looked at 4 centers, Iowa, Memphis, Toronto, and nationwide, and there was granular data collection done by the data extractors at each of these centers, hourly heart rate, FiO2, mean airway pressure, systolic, diastolic blood pressure, and so forward. And that data was then, analyzed. And what Adrienne reported is that this is a problem that happens in all centers, but the instance of each of these components varied. Predominantly, this is a hypertension-associated illness, although hypotension does occur. But this occurs across all 4 sites. And actually the one in yellow with the lowest incidence of most of these phenomena was actually the Iowa data in which milrinone is more likely to be used. So the icing on the cake, and the reason I wanted to tell this story today, is after characterizing these patients retrospectively, performing mechanistic studies to define the population, to characterize the disease, et cetera, we've just got funded to conduct the MIDAS trial, which is a multi-center double-masked placebo-controlled trial that is funded by NHLBI, which will be conducted through the Neonatal Research Network and 4 additional sites in Canada This is an important study because not only will it help us answer the question about the use of milrinone and its efficacy in this patient population, but it'll be for the first time provide kind of safety data for milrinone at 2 years of age. So really important as we embrace our career to not just be kind of in the lab or at the bedside, to do other things. And certainly when I was in Canada, one of the great highlights of my life and what kept me balanced was coaching soccer. And, I spent 10 years doing that, predominantly boys soccer. And we went to South America, we went to Barcelona, et cetera, et cetera. And that was really, really important. And I actually learned to be a leader, coaching guys on the soccer field. So what other lessons have we learned? So I had the privilege to be recruited to be the division director at the University of Iowa in 2018, and an incredible program that was doing incredible things with extremely preterm babies. We have Tara Kalezi's paper in 2019 reporting the really good outcomes. However, still some babies got sick. The PDA ligation rate was high, the NEC rate was 6%, and the severe IVH rate was 20%. Iowa is a program that's built on the people and the culture and the standardization of the care. And I'm not going to go into details here, and we can talk about that in the question and answer session if necessary. But within the domains of kind of respiratory care, nutrition care, and so forth, there was mechanical ventilation. There was great precision. The fundamental question, though, we want to ask is, how can we move with respect to these other outcomes? The world is changing. More babies are surviving. But things like IVH, we've not been able to mitigate the risk significantly. If you actually look at two great centers and two great countries in the world, there's some very interesting observations. The graph on the left-hand side is survival in Sweden. The graph on the right-hand side is mortality in Japan. However, their approaches to care are polar opposites. A very non-interventional approach in Sweden, a very aggressive approach in Japan. And despite this, survival rates are the same. So how do we explain a polarized approach to care with a similar survival rate? The field of hemodynamics is built on the basis of diagnostic precision, and based on the principle that if you have a high degree of therapeutic or a high degree of diagnostic precision and a treatment that makes sense, this is likely to balance towards treatment efficacy, as opposed to low diagnostic precision. And when you give medications loosely based on what you might think clinically with your eyes, the likelihood of the balance going towards adverse effects is higher. So if we apply that to these two countries, in the country in which everybody is getting treatments for everything, there may be kind of treatment-related harm. In the country in which we've got unrecognized disease, there may be disease-related harm. Common to both approaches is diagnostic and therapeutic in precision. So in establishing the Iowa Hemodynamics program, and again, it's grown to be now, 6 faculty. We perform up to 2,000 consults per year and have a 1-year fellowship. The question we asked is there a benefit to actually early TN-echo screening in these tiny babies? And obviously within that, you're forced to answer the question about treating the PDA. And we're not going to talk about that today. What was most interesting is if you look at some of the preliminary data that's been published, this is Jan Milliton's work from Dublin. And what he demonstrated that infants that had low cardiac output in the first 12 to 24 hours that rose rapidly, unlike babies who had stable cardiac output, were more likely to have adverse outcomes. You put this together with the work from Martin Kluckow and Nick Evans, and Martin reported that low cardiac output in the first 12 hours was associated with severe IVH. You look at Shahab's data from California, very similar to Jan Milliton's data. Infants with low output that rose rapidly, unlike those in which it was stable, were more likely to develop IVH. So how do we understand this from a physiologic perspective? Well, does that provide a missing hypothesis? After birth, you eliminate the placenta, so you create an increase in afterload to the left ventricle, which may promote the low cardiac output state, meaning low cerebral perfusion. As the lungs get better, as CO2 falls, as PO2 improves, pulmonary vascular resistance will fall, which will drive a left to right ductal shunt, which will drive an increase in preload to the left heart, an increase in cardiac output. So now the brain, which was exposed to low flow, will be exposed to higher flow. So in essence, the change in pulmonary vascular resistance may be actually driving through the presence of a ductus an augmentation in cerebral blood flow. This is particularly interesting because when you look at the trials of early high-frequency ventilation and inhaled nitric oxide, both of which were associated with an increased risk of grade 3-4 IVH. So with this backdrop, this led to us introducing mandatory echo screening with precision-based care, which involved select use of nitric oxide, particularly low dose, 5 parts per million for infants with echo-confirmed pulmonary hypertension, transitioning from using dopamine to dobutamine as the first-line drug for blood pressure and kind of abnormal heart function, and then looking at the use of Tylenol as the primary therapy for infants based on our comprehensive echo screen for hemodynamically significant PDAs. So this is just a summary kind of the data from Reagan's Blue Journal paper last year. And things change over time, and that's really, really important to recognize. You know, in Iowa, there were more babies born less than 23 weeks gestational age. The incidence in the modern EPIQ rose from 32% to 44%. A higher rate of antenatal steroid use, higher rate of delayed cord clamping, which are protective for the brain and other organs. However, as you get better at small babies, the obstetricians will ask you to come talk to mothers who are more high risk. So more mothers who have prolonged rupture of membranes, chorioamnionitis, maternal obesity. So potentially a higher risk population. What we found was that the overall incidence in the rate of death or severe IVH rate fell, as did the subcomponents. But the unexpected finding was this reduction in NEC rate from 6% to 1%. So after adjustment for the protective and adverse risk factors, screening remained independently associated, with the survival. Now, what was even more interesting, and actually the reviewers asked us to put this together, which really shows, the data over time, kind of in these epochs here. And each block reflects a 3-month time period. And what you can actually see is that as time progressed, there may be a slight marginal increase, but not statistically significant in the primary outcome, which reflects more and more 22 and 23 weekers being resuscitated. But after the year 2018, with the introduction of the program, the rate of the primary outcome fell significantly. And I can tell you for the last 2 years, when we look at our data for 23 and 24, it has continued to fall and so forth. The impact of kind of echo in premature babies, though, is not just specific to the Iowa program. This is your own data, kind of led by Sebastian Joie and Amish, which looked across sites that performed T&E versus sites that did not. And what you can see is that both pre-discharge mortality and episode-related mortality fell, as did the composite of death or severe IVH, really lending additional endorsement to the fact that there's emerging evidence that more data, disease-based data, may be helping our patients. There was another recent study published from a Spanish study, which they actually looked at kind of data from 9 centers, 5 of whom who did T and echo guided care versus those that did not. And again, a very similar finding: better systemic blood flow, better hemodynamic stability, and also a lower rate of grade 2-3 IVH and above. So, the field has changed. It's not been smooth sailing. After publishing the guidelines, the applicability to outside of North America was a challenge. A lot of places don't have echoes. The mandate, or echo labs, the mandate that the first echo must always be kind of a structural echo, led to a challenge. And also there was emerging confusion over the growth of the field of POCUS. And this ultimately led to the publication of the new guidelines in 2024, which, unlike the previous guidelines, were a neonatologist-dominated group. Unlike 2011, you can see there were 10 neonatologists, 3 pediatric cardiologists, and also we had 2 sonographers, which was a welcome addition. These guidelines really endorse the importance of a competency-based assessment, but also recognize that, our indications fall into 2 categories: symptom-based and disease-based. But there are limitations. Difficult to operationalize 24/7 T and echo. There are other things that are needed in the NICU that are heart-related. And there are still, certainly in the United States, very few training programs, which led to the growth of the field of POCUS, which we need to embrace, we need to support. but we need to work in partnership with. There are challenges. This is a Namra Leem's recent paper showing that, in centers across the United States, that there's not a lot of rigor, not a lot of standardization. Most places are performing very few studies, and issues around archiving, storage, reporting do have some work to go. But I would say to everyone here, we were at this point 15 years ago with respect to TNECO, okay? And there's no reason why positive change may not occur. But because of the uncertainty, this is one of the reasons why we wanted to integrate into our TNECO guidelines very specific indications for when cardiac focus should be used. And again, you can read it there. I'm not going to go into any details. And the last thing I would say about this particular domain is that this very elegant schematic that both Amish and Reagan put together really provides a framework how focus, hemodynamics, and pediatric cardiology can work together in a very structured and standardized way to ensure that the right patient is being seen by the right professional in a very, very symbiotic manner. So for the last couple of minutes, I just want to wrap up, to say kind of what does our future hold, and again, things are changing. Data is exploding, and we are mortal humans, and we are not able to assimilate the amount of data that is provided to us, and we must consider and embrace AI. Before 6 months ago, AI to me was, the movie, the damn robot that goes around, and I recruited Danielle, who was doing AI type work. My understanding of this was pretty limited, but I was asked to give a talk in Charleston about 2 months ago on the interface of AI and hemodynamics, and I actually learned something, in doing that. And there are a lot of exciting things that are kind of coming kind of upon us. Obviously things like sickbay, ediometry, using predictive analytics to actually help integrate data in a way that we can actually recognize when patients are getting sick. And as I say, these data will never tell you what's wrong, but they will tell you something might be wrong. Computer vision, very exciting way at automating echo and potentially looking at ways to better use kind of AI to have better ways to analyze our echoes and kind of eliminate human error. It's upon us, but there's a lot of controversy. There are many, many people that still are skeptical and do not want to embrace AI. Certainly what I have learned is that this is the future and we do need to embrace it, and that the physicians who embrace AI are more likely to be physicians that will help the field, progress. But there are still a lot of kinks that need to be ironed out. So in my world, I think AI is the vision for the next 10 years. I think we need better ways to help us recognize when something is wrong, better ways to monitor the impact of our therapies, better ways to actually, help guide the interrelationship between organs. And I think AI can certainly help that, but certainly the role of the neonatal subspecialist in echocardiography is still going to be important, because AI will not tell us what's wrong. It'll tell us you need to look at the patient again. And that's where echo will be important in helping understand the disease state. The work that Danielle is doing using AI to help predict infants with hemodynamic significant PDA, I think is very, very interesting. And she's come up with a model using the blood pressure waveform. Again, I'm not the expert on this and can't go into this, but certainly it is helping differentiate patients. So here's just one schematic that shows the probability of PDA in a patient that actually did have a hemodynamically significant shunt on the top versus one that did not have on the bottom, and in showing in the patient on the top how that changed over time and how with treatment it was certainly modulated. So I think this is very, very exciting. So to wrap up, I think we have made massive progress, and that's thanks not just to the neonatologists, but we need to appreciate the nurses, the nurse practitioners, the people that worked with us to actually help integrate our programs. We need to thank our pediatric cardiologists that have actually worked with us in a collaborative manner, because we can learn from them, and we will only be able to introduce advancements in echocardiography by that collaboration. There still is work to be done. There are still areas and gaps in science. There's still better ways to design trials that integrate echocardiography, and certainly through the pivotal trial, I think that's setting the important framework of the use of standardized echocardiography to help the adjudication of who should be enrolled into studies. And I think that certainly is an important, step forward. We need to embrace focus, but we need to work together with experts in focus and pediatric cardiology to make sure that we have, the best for our patients. So I'm going to stop there, and thank you very much for your attention.
Thank you so much, Patrick. That was fantastic to hear the whole journey. I was lucky enough to know part of it and actually was a part of that journey, but the time
And
before.
and the many hairstyles. I couldn't get the one with the long
I was
hair.
gonna say that, but that I didn't know what your hairstyle used to look before I joined you. Now I know. Um, once again, on behalf of the EPIC group overall, as well as the sub-hemodynamic group like me and Shavik leads, I think this was an excellent overview of the field and helps us understand. We have a few questions coming in from the audience. But I will first ask the panelist. Does the panelist have anything they want to talk about, or is there any specific questions? And then I'll take the three questions that I have right now in the Q&A.
No, no questions. Thank you very much. It was great.
Awesome. So maybe I and we can alternate with these questions.
Yeah.
So I'll ask you the first one. I will ask you the most interesting one that I don't know the answer of. So there are people, the question is about POCUS versus TN-echo. So there is a feeling in the field that some people feel that the POCUS or the Australian model, as they call it, CPU based care, is way simpler and easier to implement and sort of get going with compared to a TN-echo, which takes time and a lot of more effort. What would you tell those people who are debating whether they should go to the POCUS route or CPU route versus TN-echo route?
Okay, so the easiest way is to not come to work. That's the easiest thing of all. It's easier to not do any echo, okay? But we've certainly learned over time that an approach exclusively based on the clinical parameters we available to us has not really helped us progress in our domains. I would say that the one thing that is probably the greatest testament of the evolution of the field of neonatal hemodynamics are the people on this call who have established themselves as world leaders in the field, in understanding diseases, in characterizing patient populations, in helping us progress in this dramatic way that we've progressed. As I said, what I would say is in talking to people like Martin Kluckow, who's a good friend of mine, they recognize that their approach has not worked, okay? When they look at the field over the last 10 to 15 years, up to 50% of the people who were trained in the CCPU no longer use it 5 years later, okay? A lot of people are getting trained because they want to have a tick on the box when they go for their faculty job, and it's easier if you have this stuff, you look better. But the other part, and the more meaningful part, is I can spend the next 5 minutes listing all the names of people trained in North America who have become the leaders. If I now want to look at those that have come from the CCPU pathway, that list is incredibly short. I don't get past a number, one or two fingers. And therein lies kind of the challenge. And Martin, if he was here, would say certainly, the same thing. When I first talked to Luke about this, and we talked about the expert model, the most important aspect of convincing pediatric cardiology that this is important was the academic progression, because we would set ourselves apart from them. And then no one could question when we have done the research, we've developed the mechanism, we've developed the better ways of characterizing, looking at the impact of it, we've done that, okay? And I think that's incredibly important, and there are still questions to be answered. There's still research, to be done. But that, for me, I think is certainly the way forward. We have to, also recognize, and everyone that does echo recognizes that every single measurement you do has got its limitations, and why kind of, trying to rely on one measurement or a very subjective basic things is maybe not very, very reliable, So I think the work that's been done, the people who've been trained, the leaders in the field is a testament to the model. And Luke was right, and I applaud him for pushing us, to do that. Because even in our own group, there was resistance. Why do we make it so hard, so busy, so complicated? Well, I think the answer is staring us in the face.
Yeah.
Thanks, Patrick. Just one follow-up question on that question of assessment of impact, which is complex, and like CNN and EPIQ kind of gives us an opportunity to look at real-world data to try and assess the impact of interventions such as the field of neonatal hemodynamics, which has grown from where you started to now being recognized as an area of focus competence by the Royal College. So there are centers who are actively practicing as a standard of care. What would your suggestion be to CNN and to the EPIC hemodynamic group in terms of data? What data should we look at to kind of try and emphasize its impact for skeptics who are on the fence that whether I should invest in a program and both a clinical program and an academic program? How can we help?
Yeah, I think, these things are not easy questions, and again, certainly in the US, one of the things I would love to do is, because finances and dollars are much more important, is the actual health economic analysis of the impact of a program, because it does cost. And it's not just, the equipment, but, it's a complicated, discussion, because even here, there are cost savings that you don't think about. So, we need less sonographers to come to the NICU because neonatologists are doing it. There's the impact on outcomes and so forward. But any analysis needs to be very detailed, and we can't superficialize it. So, for example, one of the things that we have paid little attention to, not just in observational studies like the one from Iowa, but also in clinical trials, is that we present to people the data we collected, but then we assume that the NICUs and the way they provided care was the same, that their staffing models were the same, that the people at the bedside were the same, and we think that maybe it gets washed out over randomization, but that may not be true. And I think in any models looking at impact or efficacy, I think we need to start thinking about that stuff. What are the other confounders that could be influencing the outcomes that we don't even talk about? And some of them could be very impactful. There are programs that lose surgeons. They lose, there's many things that have a huge impact on outcomes and care that never get talked about in any form of evaluation that they do. How to do it, I don't know, Shovik, but all I would say is that in any endeavors done across the Canadian network, and the paper published on, the impact that I shared with you, I think those are great ways to provide data. But within that, not every TNECO program is the same. Okay, how they do stuff is also different, and it's not necessarily easy to just to homogenize that, but we should try to encourage as much standardization, because for me, coming from the outside to Iowa, the system that was built, the people that were there that were committed, the fact that the care didn't change from 9 o'clock in the morning until 5 o'clock at night because of the whimsical variance between people, that's really, really important. And I think that is the most important part. And, the other part as well that I think is also a lot we have all lost sight of, and we didn't even talk about it in Reagan's paper, but, when we think of echo as an intervention, the one thing we forget is that hemodynamics programs educate everybody. They educate the nurses, they educate the faculty. Everybody's knowledge improves, so they may think differently about stuff. That's very difficult to measure, but I think it's kind of important. So it's a very holistic type of thing. But I would say the more we can standardize our approaches in whatever we do, and as I said before, we really have to move towards more phenotype-based characterization of patients in trials, because preterm babies are really hard to study because so much is going on and so much changes over time. And my biggest fear, and many of you know this already, is what is the best outcome to evaluate what we do? Because we've recognized that BPD is probably not a good outcome to study. It's too complicated, it's too messy. But what's better? And I don't know the answer to that. And that's where collectively we got to work together to figure out ways, that do that, and what should be an efficacy outcome and what should be a safety outcome. So
Yeah. No,
that was long-winded, but I felt like it was a very important political question.
Well, I'll add just one line to that. Impact question, Shobek, and that's probably a little provocative. There's an impact on workload that we don't quantify, we don't say anything about. If you have a patient who is sick and you are not able to figure out what's wrong with them, and I've seen that in life all the time, 10, 12 hours, the symptoms persist. And then the acuity goes high, the RTs are busy, the nurses are busy, the faculty is busy. They're not able to sit down. On the other hand, if you're able to figure out what's wrong with them and give them the right therapy and they respond, everybody is more free to do other things and look after other patients. So, and it does happen. And then numerous times, the high acuity is not necessarily linked to busyness. It's more linked to our inability to sort out what was in front of our eyes quick enough.
Yeah. I just to add to that, like go back to Reagan's paper. One of the other things of like this early anticipatory care was that the rate of vasopressor use, nitric oxide use was actually lower, not higher. If people would think you do more echoes, you're going to give more therapies. Actually, was actually lower, which probably reflected we're preventing babies evolving in their illness, which is probably a good thing.
Yeah, so I guess, I mean, the take home is that an assessment of impact should be beyond just our traditional measurable clinical outcomes, and we need to put our heads together to think about how we can do that effectively. Amit, you have a question. I know we're coming up to the top of the hour, but we're just going to finish off with this question.
Thanks. I hope that's okay. Thank you, Patrick. A very inspirational talk. And my question is actually non-hemodynamic related. You said at the beginning that nobody should seek out success. They should seek to do good work that's impactful, and you've clearly shown that. What I was wondering, and I think you've alluded to this throughout the talk, but if you could maybe summarize, what are some key personal attributes or habits that you have, or things that you did that were outside the normal path that allowed you to have or allowed you to do such meaningful and good work?
Yeah, that's a great question. So the first thing I would say is people shouldn't try to live the life I lived because I probably worked too hard. So that's something that is not a good thing. But what I would say in terms of the things that were important to me were not to be afraid, okay? If we don't challenge the system, we will never progress. I think that was something important because it would have been very easy in 2005 to give up when you've got the might of pediatric cardiology at sick and say no, okay? But the right thing was knowing that this is going to help our patients, okay? And talking to other individuals, having good mentorship. You know, again, I didn't have another neonatologist who was hemodynamics to be a mentor, but I had other good people that I could go talk to. And I think that is very, very important. The second thing is developing the environment where people are not afraid to come and say, I don't agree or push back, I think is very important, you know, and, you know, as I said, there's not a day here, you know, I don't sit in a throne and a chair here in Iowa, just kind of the division director, and what I say in Hemodynamics Review every day that they're all going to just blindly follow. People push back and say, that doesn't make sense. Why? And that's really, really important that we create that environment that involves that debate, discussion, and support. And, you know, the other thing, you know, I would say that to me is very, very important is getting people excited. Creating something that is interesting, exciting for people, I think is really important. And that goes to the field of neonatology because, you know, we need to evolve. You know, there are less people choosing, certainly in the United States. I know it's like in Canada now, but in the United States, there are more unfilled positions in neonatology than ever before. And I think it becomes really important for us to make neonatology different. And that's why the evolution of hemodynamics, neurocritical care, and so forth is important, so that we can actually show people that you can have your own unique identity and something that's very interesting, I think, and exciting. I think is important. And, you know, I think surrounding yourself with good people, you know, I think the one thing that this field has done is it has brought the brightest and smartest people into neonatology, and many of them are on this call here. And I think that's important, you know, that we can only do good work as a team. No one individual, can do it. But going back to the very, very beginning, and I see it all the time, Amit, a lot of people come to me because now I'm somebody that has maybe some importance, and they want to get a step ahead. Because if they know me, they can do something or get something. That I don't like. That is not the way to build the field. I want people to come to me that want advice so they can go away and do good stuff to build their own trajectory. That's what we want to do with people, because everybody kind of, that the people who've really made the biggest impact have done it, and have done it in a hard way. They've had their own personal challenges and they've fought through them, and they come out the other end better off. So I don't know, did that answer your question?
Very much. That was great. Thank you.
I would add to one attribute that Patrick didn't mention, and I think probably from my point of view sort of applies to both Patrick and Prakash here, is to actually ability to take criticism positively and respond to it. And Patrick knows the amount of sharp criticism I have given him, and the amount of debates we have had.
Yeah.
But it was never off-putting to him, and I really appreciate that it actually resulted in something better afterwards.
Mm-hmm. Fully agree, and that's important. Like when I got here to Iowa as the division director, I remember saying to the faculty, there are many things I said, but the one thing is I don't want to be the division director that you're all thrash talking in the corridor. If I'm doing something, tell me. Something you don't like, just tell me. I'm a human. I want to know. I can only get better if I know.
Great, thanks. Thanks, Patrick. I see Joseph has a question. Joseph, go ahead.
Thanks, Patrick. It's fascinating talk, and I've been have privilege to learn from you for years. A quick question here is about the collaboration. We all know the collaboration, how important is machine learning and AI. But those fancy skills need a lot of those validation data set and training data set and then validation data set. So one of the barriers I can see is that how to put the many echoes from different, maybe even from different centers together to create those kind of data set. And like we have been talking about almost like 10 years ago, talk about put all the echo data, upload, and then put together there, and there are numerous barriers. So 10 years from the previous conversation, is there anything changes or anything new which will give more promise to machine learning and AI, at least from the US perspective? That's my question.
Yeah, I don't know that we've made massive progress. Certainly, I don't think things have changed yet in terms of an infrastructure, because I still think that idea is the right idea, that all the programs come together and develop a repository for echocardiography. As to who would fund that or how to get it funded, I don't know. Do we need to go back to industry as opposed to go to a funding agency? But certainly it's something I continue to be interested in. Or do we go down the pathway of disease-based repositories? So we all sit and criticize the CDH registry because it's a whole mismatch of stuff coming in together. Well, let's do something better within that domain, and that might be the way to start off with this, that we say, okay, like I think the patients which are infrequent patients across many centers in which people try to do small studies, that's a problem. If we can start pooling data together on these diseases like CDH, which are really complicated, but nobody has 100 CDH patients a year to be able to have a huge experience, I think that would be helpful to us. What I can tell you is with respect to the AI stuff, so there is a group together through our SIG, and Amish is a part of that, and some others, which is actually looking at how do we, around the subject of PDA, how do we start kind of developing an AI type work? And there are some Amish as a group, there's a group from Chalk and there's a group from Charleston that are actually starting to put together preliminary stuff around that. It's still in its infancy. As to where it'll end up, it's hard to know. But for me, I think the other part is maybe more important, which is we all struggle in recognizing when do we go back and evaluate the patient. Okay, it's easy if they get better, But if they're getting sicker, when do you go back? And can AI help us with that? I think that might be useful because oftentimes we give therapies assuming it's the right thing, but they don't always work 100% of the time. And it's like, with our PDA screening program, kind of the first echo is the PDA score of 4, and we decide not to treat. And then 6 hours later, the child has a pulmonary hemorrhage and then he has an IVH. And it's like, how could we have prevented that? Should we have gone back 2 hours later or 4 hours, whatever? Like, yeah, I think that's where AI may help us with taking all that massive amount of data. But I still think there will be a role within the imaging part itself, because some people have asked that question: if we don't have a Hemodynamics program, can we use AI to help us get some of these measurements for us to be able to help make better decisions? So lots more to talk about.
Thanks, Patrick, and thank you so much for this very inspiring talk, for inspiring like neonatologists like me and others who are on this call to kind of pursue hemodynamics, look at this field more closely, and kind of trying to integrate other attributes like research, quality improvement, to try and get this field forward. So thank you so much, and you've seen that like in the way hemodynamics has progressed in Canada.
Absolutely.
I feel it's like the feeling is mutual, I guess, to see people where they started and where the field started to where it is right now and how it is progressing. So thank you again for coming back, sharing your insights. Any last thoughts, comments before we close the session today?
No, I want to thank all of you for maintaining the momentum and accelerating, and just looking at the work that's coming out and continue to come out across the country. It makes me very happy. It was hard leaving Canada. It was hard going away, but the challenge was to actually build this in the US, and we're now up to 9 programs, and that's continuing to grow, and that's going to serve our field well to have more North American centers. And I would love to then start to replicate multi-center studies in the US, and then potentially US and Canada studies together on particular things. And that's where the pooling of data and echo data, if we had I think if we're ever to have a repository, it should not be a US or a Canada. It probably should be a kind of a North American to start with, repository. And if anyone wants to take the lead on that, I would love to see them take the lead on it. So
Perfect.
okay.
Thank you. Thank you.
Thanks,
Thank you very
everybody.
much.
Thank you
Okay.
so
Thank
much.
you.
Thank you so
Bye-bye.
much.
Thanks.
Yeah.
Thanks.
Bye, everyone.
Perfect.